all the people who make cardio-oncology around the globe, so we can share our experience and what we do. So the name is CardioOncology in Mexico, and it's a small review. Why? Because I believe that in my country, the develop of cardio-oncology is pretty slow, more slow that I would like. But we're going to start now. I mean, remember that cancer is a series of changes in the body. I mean, the cells and the nucleus of the cells are starting to change. Our DNA is going to change, and this cell with being very programmed to build specific proteins and another kind of cells that are damaged because of, I don't know, genetics and environment and I mean a lot of different variables. And when this DNA damage and with these cells are changing and this very good program change, and these cells are starting to grow with different measure and with different quantity of quality of the cells, that's what we call cancer. I mean, that's why cancer exists, and this is what cancer in a very simplistic way of thinking. No? So, but the first time that we know about that cancer, we know that the cancer can damage the heart is in 1973. I mean, 1970 with the initiation in the 60s or 70s, in the initiations with the anthracyclines, you know. So we kind of start to see that this kind of medication can damage the heart. And this is the first paper that appeared around the globe in cancer journal in 1973. I mean, I don't know you, but I don't even born yet in this date. But I'm really fascinated that to see that this is how in 1970 doctors managed cardio-oncology, because they started to think that the adrenaline can make cardiotoxicity. And this is the way they do. They do X-ray, which is in the left. We see the patient before the adrenaline and after the adrenaline for oncological problems. We see, pleural effusion and enlargement of the heart silhouette, So this is heart failure. And also they have a list of their patients, which is 111, and they say that if they die or they're alive, and they see there are a lot of different kinds of cancer, a lot of different ages, and they also measure the degree of the regression of tumor, which is in most of the cases they're not 100%. The total dose, as you can see, was, I don't know, it's just milligrams per meter square. I mean, 890, 1 gram for a meter square. I mean, this is crazy for our time. But they also recognize that there was a relationship that more of 500 milligrams per meter square, which know now that more than 550 or more than 500 milligrams per meter square, they know that they have to find muscle heart disease. So that's why I'm interested. This is the first publishing image about how the sarcomeres see when you have dose of the trimicin. And of course, they developed the first relationship of those, and those relationship heart failure. So they less than 450, 320 patients, no one developed heart failure. I mean, heart failure, because they say heart failure like in the picture of the X-ray, and they have functional class 4. I mean, but I believe that if we are if we had strain or we had BMP or we have, I don't know, more acquisition to the diagnosis in this year, I believe we're going to have changes with this. So this is part of what I want to show you today. This is the first publication. I don't know if you are seeing it, I don't know, but cardio-oncology is an emergence discipline. So we have a lot of publications since 2010. I believe we're going to see a graph right now about the statistical investigation around the globe right now. But in 2015, I believe this is one of the best articles that I read about what is going to be cardio-oncology. And they see that encompassing a continuum cardiovascular risk stratification and prevention and treatment in the patient we have cancer. So they divide it in two types. I mean, healthy patients, we have, or patients we have cardiovascular risk factors, and patients that they have already a heart disease. So with this, they divide it in two groups, and they say that cancer prevention, and then cancer diagnosis and treatment planning, and then cancer treatment, and then cancer survival. I mean, this is what cardio-oncology needs to do. I mean, they need to divide the patient, and they need to recognize she just have cardiovascular risk factor, or the patient had already have a cardiovascular disease, and then they need to do this follow. I mean, for the prevention of cancer to the treatment of cancer to and then seeing after survivorship. I mean, cardio-oncology needs to do, I believe, from here, not only attend the survivors of cancer, because the purpose of all of things of intervention is to avoid that the patient can hear they have a lot of limitation and only maybe have a palliative care. So we need to start the work around here that this article says. And this is a graph that I want to show you. I mean, look at after 2006, how the exponential growth of investigation of the term of cardiology. And this is when you put it in PubMed, which is a very large database. And this is only April of 2015. I mean, if we can start to see, right now it's more than 3,000 articles that you can see every year in different kinds of journals. I mean, right now we have a specific cardio-oncology journals, even so. So imagine that at 2015, we have 304 articles just in April. So that's why I told you that you can read right now the PubMed and search for cardio-oncology. On 2017, we have more than 2,000, and we're just in September. So this is the interest right now we have in cardio-oncology. So that's why I very applaud the intention of ICOS to unite this kind of thoughts and kind of ideas around the globe about this new term. And this is one of our president's papers that they have. I mean, it's been in Journal of Cardiovascular Failure in 2016, and the purpose of the paper was to make the cardio-oncology training, which is an idea that I applaud also, because I believe that when you have a lot of information, you need someone to help you to process and to help you and to guide you to how to apply this knowledge that you're meaning. So cardio-oncology is an inclusive discipline focused on cardiovascular health of cancer patients and cancer survivors. And this is what I told you. I mean, not only in cancer survivors, as we saw in maybe in 2014 in the guidelines, or 2013 or 2015. I mean, we need to take care of cancer patients so they don't commit when they came on cancer survivors. they just don't want, we don't want to give them only palliative care. I mean, we want to preserve this heart function so they have a very best quantity and quality of life. And the purpose of this discipline is to improve the care of oncology patients by increasing the understanding and ability and modify interaction between cancer and cardiovascular health, understand the cancer therapy, optimize the prevention and early detection of cardiotoxicity, implement effective treatment to reduce the cardiac sequels of cancer treatment, facilitate education and of health providers to optimize cancer patients, and to promote the translational and clinical research on basic understanding of the interaction of heart with cancer and cancer therapy. So this is around the globe almost the time. In Mexico, well, we have 2 centers that we do dedicate to cardio-oncology. I mean, here is Dr. Zulma Vázquez with Dr. Dan Leningham can meet in Mexico. I mean, this is one of the best cardio-oncology specialty that we have in Mexico, and that's why I tell you this. I think this is most person we have more interest, and you're going to know why in this new discipline. She works in this is the hospital of. It's curious, but the name of the hospital is Hospital for Care of Diseases about Nutrition. But they have a very large cardiology department, and Swilma is in charge of advanced cardiovascular imaging in this hospital. So they made this course this year. So we have the honor to have our president of ICOS this year, Dr. Leningham, and this is the first cardio-oncology symposium in Mexico. We have more than 350 participants. We have more than 250 computers. And Dr. Plana also helped us to make the advanced mass cardiovascular image of these patients so they can reconstruct the patient before the antransplant and 3 and 6 months after antransplant. And they can measure by their own computer and their own echo pack how the strain started to fall, how the left ventricle ejection fraction doesn't change, and all the measures that we can. So this is a very nice experience for us. We have a lot of people. Also, we analyzed the ventricular mechanics with 2 of our 3 or more experts around the globe, Dr. Bannon from Atlanta, Dr. Lowenstein from Argentina. So that's why I told you that Dr. Zulma is one of the most interested person in cardio-oncology in my country. And the second one is it's a hospital that I used to work, Hospital of Cardiology of 21st Century. This is me. So what we do in this hospital is wanted to share it with you. I mean, what we made in cardio-oncology last year, and this is information that we have, because next to our hospital, this is cardiology hospital, we have next oncology hospital. And one of the things that we have in Mexico is that the oncologist doesn't want to believe a lot of what we say. I mean, they believe that in oncology, on breast cancer, and a lot of oncological disease that are not hematological disease, they don't believe that they make a lot of cardiology damage. I mean, the heart and the myofibers doesn't be more affected. And I don't know if they're in your countries, they're the same. But in my country, it's been a very hard work to convince the oncologist to send the patient to do all the things that we follow. So what we do in 2016, well, we have 160 patients. They're all breast cancer patients. So we have a lot because this is a national center of breast cancer. We follow 1 year since diagnosis. I mean, we check the patient with no trace of any oncological treatment or nothing, you know. So what we measured left ventricle ejection fraction by 3D, tissue Doppler, diastolic function, and another measure of diastolic function like a E prime relationship. We also measure longitudinal strain, circumferential strain, left atrium volume with the 3D measuring, and also is in the guidelines only the lateral wall of the right ventricle. I mean the strain, the longitudinal strain of the lateral, because there's no specifically I don't know how to say this, specifically software for all the right ventricle. So in the guidelines, you can see that it's only of the lateral wall. So this is what we see. We cannot find changes on the inflow of the mitral inflow at 3 months and 1 year. I mean, we measure patient at the beginning, at 3 months, and after 1 year, and we cannot see changes in this. We can see change when we use tisular Doppler. We saw changing in diastolic function with this measure, and also the S wave of tricuspid annulus with TDI. We also cannot see any changes, and left ventricular ejection fraction after 3 months and after 1 year, we don't have any statistical changes. So what happened with strain of the left ventricle? This is what we see. I mean, the basal 6 months and 1 year. I mean, when this is the difference between the basal, I mean, before any kind of a transplant or trastuzumab or any other biological, at 6 months we have a little change. I mean, slightly statistically, we have a drop on the longitudinal. But after 1 year, we have more changes. But when we see circumferential strain, and this is very, very, very dissipating, because why? We have a lot of theories in left ventricle mechanics that they say that when you analyze in longitudinal strain, you're going to see changes in circumferential strain, but circumferential make it better. Why? Because they're compensating that you lost in longitudinal strain. That's one of the most of the theories about left ventricle mechanics they say. But what we saw is that also with longitudinal strain in this kind of damage, and we need to see that when we analyze the ventricular mechanics, I mean longitudinal circumferential functions, the most of the work on the papers online that you can see they are analyzing ischemic heart disease, not oncology or secondary and transplant heart disease. What we saw in this paper, that's after 1 year, both of the longitudinal and circumferential strain have dropped, even when the left ventricle ejection fraction doesn't change. And most of the experts on the left ventricular mechanics say that the reason that the left ventricle ejection fraction doesn't fall, even when the longitudinal strain is falling, is because circumferential strain maintain this. But in this case, we see that in this patient, we see that both of longitudinal and circumferential strain are forming. They make more positive as the time goes by. And this is a parameter that we measure, but we don't have a lot of information. Strain rate is a measure of diastolic function, not systolic function, because this is the deformation of the fiber in the meaning of time. I mean, we not only see how percentage of the fiber, changes. I mean, we change it and how quick they do. So it's a measure of more than diastolic function. So as we can see is longitudinal strain rate is worse, has more short is exactly like you can see in diastolic function. I mean, when the deceleration time of the mitral valve falls, I mean, is short, the diastolic function is worse. So when we try to start to look at this, is maybe be more sensitive than changes of the E and A waves on the mitral inflow. I hope I can explain it well. So we can see that by the passing of time, I mean, this is 3 months, 6 months, and 1 year, we have a drop. I mean, there's shorter of diastolic function in these patients. Also, what we can see is that when we analyze the strain of the longitudinal strain of the free wall of the right ventricle, we can see also change. We have a drop on longitudinal strain of the right ventricle, even though when the S wave of annulus doesn't change. So right now in the guidelines, we have a lot of kind of measures of right ventricle. I mean, the TAPSE, which is in M mode, the look of the displacement of the annulus. We have the S wave of the TDI, and we have this kind of longitudinal strain only of the lateral wall. So we have that even though when the TDI doesn't change, the strain longitudinal for us it was changing, and the strain rate, it doesn't have any kind of changes. But you remember that this kind of changes is only lateral wall. So we have done any software to measure all the strain of the right ventricle because of the way of the right ventricle is. I mean, remember that it's a V. I mean, you have an inlet, an apical, an outlet. So it's not any software to measure. And this is one of the cases that we have. I mean, this is the most recognized case that we have. I mean, there's only one case. We have one patient dies in this follow of the 160. This is patient who dies. Look up the strain. The strain is this kind of curve that you can see here. I mean, look the right ventricle. This is basal. I mean, before any kind of treatment, you know. Negative 19 is, or 18 is one of the best for this hallmark, because you know the benders that we have difference. So it's good. This white line is the summary of all. So this is good. So at 6 months, you can see that even when the TAPSE and the S wave, we have normal, you can see changes on this. I mean, look at -5, -10, but also the right ventricle there is not enlarged in this image. But look what happened at 1 year. This is our right ventricle of our patient. We have massive dilatation. We have left ventricle also changes. But look at the right ventricle after 1 year. Okay, now, another thing that we saw is that left atrium volume changes. I mean, they started like 29 millimeters per meter square. And remember that at the first guidelines of 2010, when we tried to measure left atrium volume, they say that plus 28, more than 28 milliliters per meter square are dilatation. So we see wrong because I don't know you, but I started to diagnose a lot of people who have left atrium dilatations because of that. So that's why in 2015 they say no, it's more than 34. And why is that? Because more than 34, it's also a relationship with the cardiovascular outcomes. So right now we know that more than 34 milliliters per meter square are dilated of the left atrium, and not 28 because 28 is normal. But what we see, our patients started at 29, 28, but some of the patients after 1 year of follow pass 38, part 37. So they have enlargement of the left atrium. Possibly, of course, we have diastolic function. I mean, we have a lot of things that we can change. I mean, maybe some of only of this in this 100 autistic cohort of patients, we only have three women with blood hypertension. So what we saw in these cases, we have 3 patients. We have palpitation. When we have 12 patients with palpitations, I mean, they felt palpitation, but feeling palpitation in a patient we have cancer, it can be I don't know, anxiety or I don't know, stress or something. But in these 3 patients, we can see atrial fibrillation, and these 3 patients doesn't have blood hypertension. And also, these 3 patients pass the 38 milliliters per meter square. We discussed a lot of this with experts. I mean, atrial fibrillation can come from stress. I definitely don't say that don't. Also, they kind of started to have blood hypertension, and maybe it is not follow right because this patient doesn't have weekly clinical testing, or I mean, we see them every 3 months. I mean, they can change. They can have blood hypertension or something. But it's curious to see that this kind of relationship of the anthracyclines treatment and the enlargement of the left atrium and also present of the atrial fibrillation. I mean, we need to be more careful with this information because of the thing that I saw. It can be stress, it can be starting with blood hypertension. But it was very curious to find this in the patients. So, to conclude this little webinar that we wanted to show you is that cardio-oncology is a global problem. I mean, we don't need to discuss. We are very interested in this matter and this discipline, and we have more than 10,000 publications that say that it's a cardiovascular global health problem. Around the world, there is an exponential growth of the belief on believing that in these new disciplines and in the forms of diffusion. In Latin America, we still have difficulties for the establishment of the discipline and also in daily use. I mean, because we can believe something, but we cannot use it every day. I mean, this is different. I mean, in day-to-day, on the patients, on the hospitals, it's very difficult to make the changes in a lot of minds, a lot of oncologists thinking that this is real. And in Mexico, we still need more studies and more evidence to convince the oncologists and cardiologists of this discipline. And the road is still so long. So thank you very much. I hope this little webinar is good.
Super. Thank you, Rafael. That was really cool.
Let's see if anybody has any questions.
Yeah.
Any comments or questions?
Yeah. The 160 patients. How detailed or what percentage of those 160 patients had follow-up echoes at 3 months and at a year? Did all of them have 3 echoes at least?
Hello, Rafael. Are you still there?
Eric, can you hear me?
Yeah, I can hear you. You stated your question well. I think somehow we've lost Rafael's communication here. But he's still signed up, and he is still the presenter, but he's not talking to us.
Is there any comments?
Rafael? So I see he's moving his arrow, but I'll chat with him. I'll put a little.
It looks like he can't hear. He can't hear us.
So,
Dr. Harrison, can you hear me?
Raphael,
Hey, Raphael, we hear you again.
we can hear you, Raphael.
We still in the system there, Eric?
Yeah, everybody's still in the system and on point here.
Yeah.
So,
well, I think that, you know, the fact that he has 100.
Is anyone?
Yeah, I guess you're kind of cutting out, Raphael. But I was mainly wondering, how complete is your data set, the 160 patients? Does every one of them have at least 3 echoes?
so we're not able to get Raphael right now. Let's see, he's all signed up. Everything seems to be functional. So I'm not sure what's happening. So we will make sure he's the presenter again. Hang on here. Maybe he lost his capability of being the presenter. So I'm making him the presenter again. Raphael, you are back as the presenter.
Okay, thank you.
There you go.
Okay, I hope this webinar can be of your, they like you. And this is a really small view of what happened in my country and around the globe. So I hope you like it.
Oh, very good. Can you, did you hear my question from a minute ago?
No, so I'm sorry. I just have a problem with my sound.
No problem. How complete is your echo data on those 160 patients? So did they all get echoes at baseline 3 months and a year?
Yes. We have in this database we have like 180, but we need to quit 20 because they don't have this follow. I mean, at the beginning 3 months, 6 months, and 1 year. So that we need to don't use this all the 20 patients because this 160 we have all the information, and also we have the information of the dose of the trastuzumab they use on the patient.
Do you have any do you know whether they were treated with any cardioprotective medication like carvedilol or an ACE inhibitor or any of that?
No, they don't use anything on the patient. I mean, there are only 3 patients we have blood hypertension, and they use losartan for the control, but they don't have any kind of cardioprotection medication.
And then for what percentage of that 160 patients had hypertension?
Of the full population, the percentage is very small. I mean, we have every day they have 20 or 25 diagnoses of breast cancer in this center. I mean, this is a very large center in Mexico. So, I mean,
right.
I don't know.
But I mean, of the patients that you had all that good follow-up data on, what percentage of those patients required losartan?
I believe that in the minute that we're starting to see changes on this kind of measuring, like I presented in here and all these things, and this let me see. When we started to see this, I believe that this group of medication of maybe, I don't know, carvedilol or enalapril, we can use this in this. how many percentage? I mean, like 70 or 60%, because you know this is only 1 year of follow. I mean, if we follow maybe 3 or 5 years, we're going to start to see changes on this and on the left ventricle ejection fraction. As you see, left ventricle ejection fraction at 1 year, they have changes, but slightly upper the statistically. I mean, if I follow maybe 3 or 5 years, I assure that this is going to change because of this. So I believe that maybe 60 or 70% of the patients that have this treatment and then this follow, they're going to need some of cardio protection for avoid these complications.
Right. What happened with those patients that you followed? Of those 160, how many of them had strain changes? And then of those, how many of them got losartan?
Okay. Well, remember that this cohort is for 2016, 2017. So it's difficult for us to have this kind of control because we are a hospital which is not the main hospital of the treatment. So there are a lot of patients. I mean, the full pool of patients were more than 200, but the people doesn't come back because we are not giving any treatment and they have oncological problems. So in this reason, they don't come back to us because we are only measuring things, you know. From this follow, the straight changes more than 90% of the patient of the 160 patients, and in this 90 patients, they need to use any kind of cardio protection. I believe that, but for us it's difficult because I cannot give the treatment because it's not part of my hospital. I don't know if I explain me well. It's a lot of I don't know, bureaucracy and all kind of stuff. But I cannot give it to them. I give it a letter to their specialist that I recommend to use this. But I cannot give it the medication to the patient because there's not my patient. I don't know if I explain me well. So this is an oncological.
You explain it well, but I think that that's you know, honestly, that's the real barrier. The barrier is not whether you do this strain and you find a change because you did that, you demonstrated that. But the barrier is how do you actually change practice?
Exactly, to do something about it.
Yeah, so you know, it's not good enough. I'm not saying that what you did is not good enough. I'm just saying for all of us, it's not good enough to just find a problem. Yes. We need to make a change in how the patients are treated or followed or whatever. So in your case, if losartan is the drug that's available, it's a good drug. The question is that for anybody who has those types of strain changes, if they need to be put on losartan, we need to figure out how to get that done.
Yes, that's why I told you that, and then my conclusion is that we need more data and we need to be more incisive on this specialist. I mean, because not only oncologists, even cardiologists, when they are not very familiar with, you know, all these ventricular mechanic things, no, they don't understand what we're doing. I mean, what are you telling to me with this? I mean, left ventricle ejection fraction is okay. They don't need anything, so they can move on with their lives. No, I mean, this is why we measure ventricular mechanics. But I believe we need to explain that not only the oncologists, to clinical cardiologists, which is the meaning of this, so they can understand, they can start medication on this patient. And of course, I know this is the problem, and that's why I'm showing you what are my problems in my country right now. This is exactly the problems that we have now. I don't know if in the other countries it's the same, but in my country, to believe that these patients need more medication, it's hard to understand for all my colleagues, because they say that we are making diseases where they don't be. I mean, no, I don't know if I explained me well with this, but they they think
they're saying that your findings are not relevant. They don't really have any greater meaning.
This.
But you know, I would say, you know, think about it like your car. So your car, you follow you measure the tread on your wheels, and when the tread gets below a certain mark, you know, most people would say you probably ought to change your tires. Now, if you measure the tread and it gets below a mark and then you do nothing about it, then, you know, it makes you go back to, why do you even measure the tread on your tires? You know, and the reason is because you can anticipate that if you have no tread in your tires, you're probably going to get a blowout. And, you know, so the thing is that it's a tool to indicate a change. And so what we have to figure out is, how do we change the tires? You know, how do we get the people to get the medicine and actually take it?
Exactly. Yes, because I know, I mean, I understand perfectly that, but I have especially some colleagues that say that I am putting diseases when they don't exist. I mean, you're making people sick before. I mean, no, I'm trying to prevent damage. I mean, it's difficult. I mean, that's why Dr. Silva and we made this summit specially for that. I mean, with the diffusion of the cardio prevention and cardio-oncology measures that you need to take. I mean, we have Dr. Juan Carlos for this kind of ventricular mechanics, and you for the biomarkers, and trying to explain to people that we're going to try to do is not making people sick before. I mean, we're trying to avoid complications, but this is the dilemma that we have now in Mexico. Exactly. So your point is very well, Doctor.
Yeah, well, I mean, we have the same issue in the United States, so don't feel like you're alone in that challenge. Yeah, no, but I think that, you know, from our point of view, from ICOS's point of view, we have to figure out how to change the tires, exactly. how to make the practice different.
I believe that the thing we can do is make I don't know how to say. Well, we have a practical guidelines in the United States. I mean, guidelines for practice, but for medical practice. But in Mexico, we're trying to do, Dr. Wilma and I, is make it it's like guidelines, but it's more specifically like I don't know how to say. It's not law, but it's normative. I mean, they believe it's normative. I mean, we're going to try to explain this to different kind of specialists all around Mexico. So we can make a paper, a document specifically in Mexico. So how we need to treat this patient. And with this, maybe we may establish and landing this information in our country. Because you know, in different countries we have different kind of make this thing happen. I mean, you have practical guidelines or something in the United States, but in Mexico we need to change, and we need to do our special guidelines for Mexico in our people, in our ambience, with our medication, which is different that we have in the United States. And that's a project that we have with ICOS and with you and Dr. Silva. We wanted to do it in I don't know, together, so we can apply in Latin America and Mexico.
Yeah, absolutely.
Let me ask some others if they have any questions. Thelma, I think you just logged in. How are you today?
Good morning. I'm very pleased to be here with you today. I'd like to say that I'm also from Mexico City. I'm a cardiologist. I work at 1st of October Hospital from ISTE, and I'm very proud of what Dr. Rascon and Dr. Swilma are doing, I only wanted to share another experience. Where I work, it's a general hospital, so we can have the opportunity to have the oncologist service and the cardiologist service in the same building, and we can, as cardiologists, assist to the tumor meeting every week, so we can interact both groups, cardiologists and oncologists, and some other specialties. And it's easier for us to continue seeing the patients and start carvedilol or ACE inhibitors or whatever else is needed, statins. And I just wanted to say to Dr. Raskan that I understand him if he works in a hospital that doesn't have the oncologist there. There are two different institutions, and it's difficult to follow the patients. But in a general and smaller hospital, it's easier, I think. I also share with him the idea that sometimes oncologists don't believe, but it's work that you should be doing every day, every week, and also trying to convince cardiologists in our hospital, because nowadays all the cardiologists are focused on ischemic cardiac disease, and day a day we'll try to convince them that it is a very important specialty. And finally, I will tell him that I can contact him, and if you want some other hands working for our guidelines, I could help.
Of course, thank you. I formed in the, well, Dr. Hugo Velasquez was my teacher in 1st of October on echocardiography, so I recognize the hospital very well. I formed my echocardiography and advanced cardiovascular imaging in 1st of October with Hugo Velasquez, so I recognize the hospital, and it's very glad to know something, so not someone in these meetings about that hospital, which I admire because it's what my my home for echocardiography. So it's nice to meet you.
Nice to meet you.
I think, I will just say that, the meeting you guys held in Mexico City was really impressive, and I think it's an example of what we need to do. But I think that the struggle that we just talked about that you guys may have, I would say we have the exact same struggle. So don't feel like you're alone in this regard. This is our personal challenge to figure out how we can get people to recognize the problem, but then change therapy to improve it. Not just say that it's this is, you're making up a disease. We're not making something up. This is a real thing, and we can prevent it if we look for it early and detect it early. Then we can prevent it from progressing. And, every disease, cancer or heart disease, whatever disease in the world, is always better when you prevent it than whether you try to deal with it when it's end stage.
I would like to welcome Serena Messer. Serena, hello. How are you this morning? I'd like to welcome Suma Kanati. Suma, we're glad to have you here. Barry.
Thank you.
Yes, how are you today?
I'm good, thanks. I'm joining you from Minneapolis, and this is my first time on the call.
Yes. And so we're glad to have you here from the, are you from Aurora Medical Center, or where are you from?
I'm from the University of Minnesota, Minneapolis.
University of Minnesota, very good. Well, we're so glad to have you here, and I know you're a late arrival, probably because of my failure in terms of messaging, but sign up and register for the year, and we're hope that you can continue to attend with us.
Thank you. I'll try.
Yeah. And so Barry Trachtenberg is registered here twice. Barry, can you talk to us?
Yes, hi, I'm here in Houston. Enjoyed the talk.
How are you doing there in Houston? You doing okay with the floods?
Yeah, we're doing okay. Some of our staff got flooded out, but for the most part, we're getting back to normal.
Yeah, that was a huge deal. So sorry you had to go through that.
Oh, thank you. Appreciate that.
Well, we want to thank everybody for attending today, and hope that we'll be seeing some of you in London next week, and if not, then for sure in Tampa the following year. And so some of you that can travel easier to Tampa, we will be welcoming you next year. And so as soon as we get cleaned up over our hurricane, we'll have everything ready for you. And no more hurricanes here in September.
And we can see the Buccaneers.
Yes. So, thank you everybody for attending today, and a special thanks to our presenter, Raphael. That was very interesting. You're doing a great job in tracking disease. We have the same problem here where there's probably the largest private oncology group in the country that spans multiple counties. And we have 2 doctors that regularly refer patients for cardio-oncology out of a very huge group. Private practice needs even greater penetration by cardio-oncology. Universities have paid a lot more attention and have created divisions and chairmen and so forth. But private practice is a vast area underserved. So we're looking forward to having more encounters with private practice. Hopefully we'll have Dr. Post join us, who is the first HCA cardio-oncology clinic in Pinellas at Palms Hospital in Pinellas. And so thank you so much, everybody. We look forward to next month, and we hope that others will register, and we'll make sure that at the meeting in London we get more information out to everybody. Thank you. Bye-bye.
Bye-bye.
Very good. Thanks.
Bye.
Oh, no.